Spinal cord injuries by Dr. Mohammed Al-Tamimi, a consultant neurosurgeon and an assistant professor. The objectives of the lecture will be talking about the incidence of spinal injuries, anatomical background, the types of spinal injuries, clinical and radiological signs of clinical significance, spinal shock features and the management protocols. Regarding the incidence, about 10 to 15 persons per million each year are victims of spinal injuries. Most of them, they are young people. The males are more affected than the female. Most of the causative factors ranges between the road traffic accident by about 51%, domestic and sport injuries, and industrial and self-harms. Regarding the areas, the cervical area is the most area to be affected by spinal injuries. It accounts for about 40% of the cases. Comes next to it is the dorsolateral area by about 35%, and then the thoracic, and then the lumbar and extra. If we pass through some anatomical review of the spinal column and the spinal cord, we have to know that the spine, also known as the vertebral column or the spinal column, is a column of 26 bones in an adult. 24 bodies, separated vertebral bodies, interspace with cartilages, and then additionally the sacrum and the coccyx. But prior to the adolescence, the spine consists of about 33 bones because the sacrum's 5 bones and the coccyx 4 bones, they do not fuse together until the adolescence. The vertebrae are named by the first letter of the region, C for cervical, T for thoracic, and L for lumbar, with a number to indicate their positions along the superior-inferior axis. Each vertebra has several important parts: the body, the vertebral foramen, the spinal processes, and the transverse processes. Regarding the body, it is the main weight-bearing region of the vertebrae, making up the bulk of the bone's mass. Extending from the body are the transverse processes, which are thin columns of the bones that point out to the left and to the right side of the body. The spinal process extends from the ends of the transverse process in the posterior direction. Between the body, the transverse processes, and the spinal processes is the vertebral foramen, which is a hollow space that contains the spinal cord and the meninges. Between the vertebrae of the spine are 3 regions of the cartilages known as the intervertebral discs. The vertebrae of the spine align so that their vertebral canals, they have to form a hollow bony tube to protect the spinal cord from external damage and infection. The canal is protected by the ligaments. These ligaments, they range from the ligamentum flavum posteriorly and the posterior longitudinal ligament anteriorly. The outermost layer of the meninges, the dura mater, is closely associated with the arachnoid mater, which is in turn is closely connected to the innermost layer, the pia mater. The meninges divide the spinal canal into epidural and subarachnoid spaces. The pia mater is closely attached to the spinal cord. Between the vertebrae are small spaces known as the intervertebral canals. They allow the spinal nerves to exit the spinal cord and connect to the various regions of the bodies. This is a picture shows the spine posteriorly with all the ligaments and the meningeal coverings. The spinal cord, in turn, is a long fragile tube-like structure that begins at the end of the brainstem and continues down almost to the bottom of the spinal column. The spinal cord consists of the nerves that carry incoming and outgoing messages between the brain and the rest of the body. It is also the center for the reflexes. Like the brain, the spinal cord is covered by 3 layers of tissues, the meninges. The spinal cord and the meninges are contained in a spinal canal. The cord has a central gray matter and a peripheral white matter. On looking at a cross-section of the spinal cord, it has got the ascending tracts for conveying informations to the brain and the descending ones for conveying informations from the brain, as shown in this picture. The spinal cord ends about 3/4 of the way down the spine, but a bundle of nerves extends beyond the cord. This bundle is called the cauda equina because it resembles the horse tail. We have talked in the clinical lecture about the clinically important ascending and descending tracts. We know that the most important clinical ascending tracts are those who are conveying the informations, just like the deep sensations and the superficial ones, from the peripheral sensory organs up into the peripheral nerves and all through the way up through the spinal cord into the somatosensory cortex. On the contrary, the descending most important tracts, the motor tracts, they convey informations from the motor cortex in the brain all the way down through the cord and then into the motor areas and the muscles. From the clinical point of view, which is very important to know in the anatomy, that the spinal cord, it ends below the lower border of the L1. This is in the adult. In the children, usually it ends at the level of L3, L4. The spinal levels that doesn't correspond to the cord level. That's for the cervical area region, and in order to get the correct corresponding cord level, we have to add 1. For the T1 down to T6, we have to add 2. For T7 down to T9, we have to add 3. For Tn, it corresponds to the L1 area. And for the L2 level, for T11, it corresponds to L3. For L4 level and L1, it corresponds to the sacrococcygeal area. The coda equina starts at the level of the L1, as we said in the adults. The mid-dorsal spinal cord and neural canal spaces are of the same diameter and hence prone for complete lesions. In the mechanical injury, early ischemia and the cord edema with the resultant cord necrosis are claimed to be the most important factors that determine the prognosis. Neurological recovery is unpredictable in the coda equina. Spinal stability plays a very significant role. The spinal stability depends on the theory of 3 columns. These are the anterior column, which is consisting of the anterior longitudinal ligament, all together with the anterior annular ligament and the anterior half of the vertebral body, while the middle column is consisting from the posterior longitudinal ligament, all together with the posterior annular ligament and the posterior half of the body. The posterior column in turn is consisting from the ligamentum flavum and the superior and the interspinous ligament and intertransverse capsular ligament, all together with the neural arch, the pedicle, and the spinous processes. Now, what's the significance of that? The spine is regarded as being unstable if the middle column, all together with either the anterior or the posterior column, are damaged. Rupture of the interspinous ligament is associated with the avulsion of the spinous processes with an unstable spine, and further flexion increases the neurological injury. Regarding the spinal trauma, we have to know that it has to be divided into either affection of the spinal cord or affection of the bony part, that say the spinal fractures and the dislocations. Cord injury, it is defined as a damage that causes changes in the cord function, either temporary or permanently. These changes can translate themselves into loss of the muscle function, sensation, or autonomic functions in parts of the body served by the spinal cord below the level of the lesion. The injuries can occur at any level of the spinal cord and can be classified as either complete, that say there will be a total loss of the sensation and the muscle functions, or incomplete, which means that some nervous signals are being able to travel past the injured area of the cord itself. It can also be classified as either being chronic or acute. We talked previously that the cervical region is the most area being affected. In the classification of the spinal cord injuries, it can be classified as either according to the mechanism or according to the level, being either affecting the skeletal or the neurological or all together. Or it may be classified according to the completeness of the injury. In the mechanism of the spinal cord injury, there are 2 important factors, the primary insult and the secondary insult, which is caused by multiple chain of events triggered by the original insult itself, leading to progressive cell death and progressive inflammation. In the terminology, when a patient has got a complete lesion, he will be named diplegic. When the patient has got some muscle strength being preserved, he will be named paretic. Tetraplegia means that the patient has got an injury to the cervical spinal cord. The patient can usually still move his arms using the segments above the injury. For example, if the patient has suffered an injury to the C7, the patient can still flex his forearms using the C5 segment. Paraplegia is a name for the patients who have got injuries to the thoracic or the lumbosacral cord or the chorda equina. Means that the patient is still moving the upper limbs, but he has got a problem of the lower limbs. Hemiplegic means that the patient has got a paralysis of the one half of the body. Usually those happens at the brain injuries and to a very lesser extent with the spinal injuries. How to assess the level neurologically? We have to examine the patients completely. We have to examine the motor, the sensory, and the reflexes. So in the motor examination, which are called the myotomal areas assessment, that's by examining the muscle bulk, the power grading, the muscle tone systematically, and getting out what we call it the agiomotor scoring system. We have talked about that in the clinical session. We have to always remember that the motor level is the last level with at least 3/5, let's say, against the gravity function of the muscle. This is the agiomotor scoring system for the extremities. Now, how to assess the level neurologically? Also, we have to examine the patient's sensory system. We have to assess all the modalities of the sensation by examining what we call the dermatoma regions systematically, and we have to identify the sensory level, if any, as shown in the next image. The sensory level is the last level with the preserved sensation. This is the map of the distribution of the dermatomes, and we have got certain key points, just like the C4 for the shoulders, and the T10 for the umbilicus, and the S1 for the lateral malleolus, and so forth. Also, we have to examine the deep tender reflexes in order to assess the level neurologically. So on the arms, the C5 accounts for the bicipital reflex, and the C7 for the tricipital reflex. Styloradial reflex in the C6. For the legs, as we know that the patellar L3 and some L4, Achilles tendon reflex is the S1. We have also to assess for any pathological reflexes, just like the Babinski, the Hoffman, and the Clonus. We have also to assess for the important vegetative functions when they are being affected. Always put in your mind to differentiate between the upper and the lower motor neuronal lesions, and that's by assessing, of course, the muscle tone, tender reflexes, the pathological reflexes, and the muscle manifestations, and the possible etiologies, and we talked about that in the clinical session. So to determine the level of the injury specifically, we have to assess the motor reflex, the last level with at least 3/5. We have to assess the sensory reflex level. This is the last level with the preserved sensation. We have to assess for the radiological level, that's say the level of the fracture on the plain X-ray, the CT or MRI, if any. We talked previously that the spinal level doesn't correspond to the spinal cord level below the cervical region. So back again for the cord level, for example, at the C2, C7, we have to add 1 for the cord level. For the T1 to the T6, we have to add 2. For T7 to T9, we have to add 3. For T10, it corresponds to the L1 and the L2. For the T11, it corresponds for the L3, L4. L1 is a correspondent for the sacrococcygeal segments. So, what are the signs and the symptoms? It depends on the level of the injury and the degree of the spinal cord being affected. Complete spinal cord injury means that all the functions being affected and lost. That's say the sensory, the motor. Incomplete spinal cord injuries, it involves the preservation of the motor or the sensory function below the level of the injury in the spinal cord. And usually there must be some preservation of the sensation or the motor in the areas innervated by the S4 to S5. Example, voluntary external anal sphincter contraction, as the nerves in this area are connected to the very lowest region of the spinal cord, thus retaining sensation and function in these parts of the body. What are the incomplete spinal cord injuries features? We have got the anterior spinal cord syndrome, the posterior spinal cord syndrome, and we have got the Brown-Séquard syndrome and the central spinal cord syndrome. In the anterior spinal cord syndrome, it's due to the damage to the frontal portion of the spinal cord or reduction in the blood supply from the anterior spinal artery. It's always caused by fractures or dislocation of the vertebrae or herniated discs. Below the level of the injury, the motor function, the pain sensation, the temperature sensation, all are lost. While the senses of the touch and the proprioceptions, that say senses of the position in space, they remain intact. You can see at the picture here how the affection can translate itself clinically. For the posterior cord syndrome, where just the dorsal column of the spinal cord are injured, usually it occurs in cases of the chronic myelopathy and infarction of the posterior spinal artery. This rare syndrome causes the loss of the proprioceptions and the sensation of the vibration below the level of the injury with the preservation of the other spinal cord functions. For the Brown-Séquard syndrome or the hemicord syndrome, which occurs when the spinal cord is injured on one side much more than the other one due to the penetrating wounds, just like the gunshots or the knife wounds or fractured vertebrae or tumors. On the ipsilateral side of the injury, the body will lose the motor altogether with the proprioception and the vibration and touch. On the contralateral side, and because of the anatomical distribution of the trunks, we will get loss of the sensation and the pain and the temperature. Regarding the central cord syndrome, which usually results from the neck hyperextension in the older people with the spinal stenosis. In young people, it results from neck flexion. Patients usually presented with weakness in the arms. Arms are more affected due to their central location in the spinal cord, and relative sparing of the legs due to their more external location, and the spared sensation in the region served by the sacral segments. Sensation of the pain, temperature, light touch, and pressure below the level of the injury are lost as well. In the coda equina versus the conus medullaris, you have to put some differentiation points. So for example, in the conus medullaris, that's the end of the cord at the level of the L1 and L2, the injury affects the ends of the spinal cord located at that level. This region contains the S2 and 3 and 4 and 5 spinal segments. These are responsible for the bowel and bladder and some sexual functions, so they can be affected. While in the coda equina syndrome, that's say at the area of L2 down to S5, the peripheral nerves already branched off from the spinal cord and they are being affected mostly, resulting in low back pain, weakness, paralysis in the lower limbs, loss of the sensation, bowel and the bladder dysfunction, and loss of the reflexes. Unlike the conus medullaris syndrome, the symptoms often affects only one side of the body. So what are the goals of spinal trauma care? You have to put in your mind that you have got certain goals you have to fulfill. You have to protect from further injuries during evaluation and management. You have to identify the spinal cord specifically and to document any abscess of the injury. You have to optimize the conditions for the maximal neurological recovery. You have to put in your mind that those cases are the highly suspicious of having spinal injuries, high-speed crash patients, unconscious one, multiple injuries, a neurological deficit, a patient with a spinal pain and tenderness. Always put in your mind that up to 15% of the spinal injuries have a second possible non-adjacent fracture elsewhere in the spine. So whenever you discover a spinal fracture or an injury, you have to search for another level nearby. The initial management ranges from the immobilization using rigid collars, sandbags, spinal boards, log roll to turn. You have also to prevent the secondary insults through treating and preventing the hypotension. through maintaining a good oxygenation. If intubation is needed, do not move the neck. You have to always use the ATLS guidelines. In the hospital, the management ranges from starting with the ABCs down to putting an NG tube for suctioning to prevent the aspiration, to decompress the abdomen, especially for the paralytic ileus, which is very common in the first days. You have to put a urinary catheter, that's say the Foley's, for urinary retention, which is very common. Methylprednisolone or solumedrol has got its controversy over the use. In the radiological examination, you have to start with doing an X-ray. Always put in your mind that protocol, the AA, B, C, D, S. A for adequacy and alignment, B for the bone abnormalities, and you have to search for the base of skeletal problems, C for the cartilages, disc for disc spaces images, and S for the soft tissues. In the adequacy, it means that you have to visualize the entire spine being viewed, whether being cervical, thoracic, or lumbar or lumbosacral and sacrococcygeal. In the cervical, for example, in order to get an adequate view, caudal traction on the arms may help. If you cannot, you have to get a swimmer's view, for example. In the alignment, you have to see that all the vertebral bodies with all the compartments being well aligned. You have to draw what we call the anterior vertebral line, the posterior vertebral line, and the spinolaminar lines. They should always have a smooth curve with no steeps or discontinuities. Malalignment of the posterior vertebral bodies is more significant than that which happens anteriorly, which may be due to the rotation. A steep of more than 3.5 millimeter is a significant anywhere. So in the lateral cervical X-ray, it's very important to look for the alignment to exclude any anterior subluxations. Regarding the bones, the architecture and the bone build should be nicely built. So you have to draw the lines regarding all the bones. You have to see the bodies, the lateral masses, the spinous processes, the laminae. All them, they have to get an intact bone marks. Regarding the disc spaces should be uniform. You have to assess for the spaces even between the spinous processes. The vertebral body height should be uniform, and you have to check for any oblique fractures. There are certain views that may help in certain fractures, just like the open mouth view for the odontoid fracture, for example. X-ray alone is not that significant in revealing any bony fractures, so we may use the CT scan. The CT is very good in acute situations. It shows the bone very well. Sagittal reconstruction is mandatory. However, the soft tissues, just like the discs, spinal cord, are poorly visualized. Don't give any contrast in a traumatized patient. We may further evaluate the cord and the soft tissues by doing the MRI. However, the exception is the Coda equina syndrome. It shows tumors in the soft tissues and any hemorrhages better than the CT. It may be used to clear the cervical spine in comatose patients. Sometimes we may use the cervical tractions, just like using the Gardner wheel tongues. That provides temporary stability of the spine. However, it's contraindicated in unstable hyperextension injuries. The weight, it depends on the level. Usually we use 5 pounds per the level. Cervical collars can be removed while the patient is in traction. You have to take care of the pin at the site of the insertion. You have to take multiple X-rays at regular intervals and even after every movement from the bed. We'll pass now through certain fractures, just like the Jefferson fracture, which is a burst fracture of the C1 ring. It is an unstable one and usually can be revealed on the CT scan. Burst fractures that can affect the bodies from the C3 down to the C7 from the axial loading. The spinal cord injury is very common from the posterior displacement of the fragments into the spinal canal. It is an unstable one. Clay-Shobler's fracture, which happening on the C7 more than the C6 more than the T1. It is a stable one and happens with the flexion fractures of the spinous processes. Flexion teardrop fractures. Flexion injury is causing a fracture of the anterior inferior portion of the vertebral body. It is unstable because usually associated with posterior ligamentous injury. Bilateral facetal dislocation, just like in this picture, it is a flexion injury with a subluxation of dislocated vertebra of greater than half of the anterior posterior diameter of the vertebral body below it. There is a high incidence of spinal cord injury. It is extremely unstable. Hangman's fracture, it is an extension injury with bilateral fracture of the C2 pedicles, just like that shown in the white arrow. There will be anterior dislocation of the C2 vertebral body, just like what happens in the red arrow. It is totally unstable. Odontoid fractures, it's a complex mechanism of injury. Generally, it's unstable. It has got three types. Type 1, the fracture passes through the tip. Type 2, fractures pass through the base. Type 3, fracture passes through the base and the body of the axis. This is a type 1. This is a type 2. And type 3. This is a picture shows the gardener's wheel tongs used for the traction. What are the options for the patients with a spinal injury? It ranges from either leaving the patient for conservative treatment or a surgical decompression, with or without a fusion. The indications for the surgery ranges from the decompression of the neuronal element, just like what happens in the spinal cord and the nerves compression, or stabilization of the bony elements of the spine. The timing usually is emergent, especially with the incomplete injuries with a progressive neurological deficit. However, sometimes we may use it on an elective way, just like for the patients with the complete lesions, that say about 3 to 7 days post-injury, especially with the central cord syndromes, where we may do it at about in the second or the third week post-injury. Soft collars and hard collars are very mandatory in the cases where we suspect that the spines are being unstable. However, they are not sufficient always, and especially being used post-surgical. Minerva vest and hollow vests may be used also for some cases. Don't forget that the long-term care is very important for those cases of the spinal injuries. So rehabilitation for maximizing the motor function, bladder and bowel training is very important, all together with the psychological and the social support. Thank you.